To understand a client's distress, a counselor needs a working map. If the therapeutic relationship is the foundation of addiction treatment, specific theoretical frameworks act as the upper floors of the clinical architecture. One of the most structured of these frameworks comes from psychiatrist William Glasser, who developed what is known as choice theory. The core premise of this theory is direct. Nearly all human behavior is an active choice, driven by an ongoing attempt to satisfy a set of intrinsic human needs. Glasser identified 5 of these needs: survival, love and belonging, power or achievement, freedom, and fun. Substance use, in this view, is an active choice to satisfy these needs, however ineffective that choice may ultimately be. Choice theory models this through total behavior. Every action has 4 inseparable components: acting, thinking, feeling, and physiology. While all are connected, a person has the most direct control over acting and thinking. Change the actions and thoughts, and emotions and physical states follow. The clinical application of this theory is called reality therapy. It operates with a strict focus on the present moment, deliberately steering away from long analyses of the past and rejecting historical excuses for current behavior. The primary engine of this approach is the WDEP system. The counselor starts by exploring exactly what the client wants, and then examines what they are currently doing to achieve it. Next comes a rigorous evaluation. Is what you are doing actually working? Once the client recognizes the disconnect, the final step is committing to a concrete plan for more effective behavior. Because it demands active self-evaluation and forward-looking planning, reality therapy aligns perfectly with the broader recovery movement's insistence on personal responsibility and active choice. But reality therapy is only one tool. No single framework addresses every dimension of the addiction experience, necessitating a broader clinical arsenal. A psychodynamic approach looks backward, examining how past relationships and unconscious patterns dictate present behaviors, offering insight into deep-rooted emotional triggers. Family systems thinking steps out to view the individual within their relational web. It outlines how a family unit can either support sobriety or actively undermine the client's recovery. On the behavioral side, contingency management is an evidence-based method that relies on the immediate, tangible reinforcement of verified behavior changes, like providing a reward for a negative drug screen. 12-step facilitation offers a highly structured method to link clients directly to outside mutual help fellowships, bridging clinical work with community support. Mindfulness-based approaches train clients to cultivate a non-judgmental awareness of the present moment, teaching them how to ride out intense waves of stress and craving without reacting. Solution-focused brief therapy pivots away from the history of the addiction entirely, concentrating instead on the client's existing strengths and analyzing the times when the problem is absent. And motivational interviewing serves as the primary, evidence-based tool for exploring and resolving a client's deep ambivalence about whether they even want to change. Possessing this broad range of theoretical lenses ensures a counselor avoids the error of forcing the client's complex culture and readiness stage into a single rigid paradigm. Yet every technique we just covered will fail, or even provoke active resistance if it is delivered without a foundational therapeutic alliance. Before any functional analysis or treatment plan is introduced, there must be a relationship. That alliance relies entirely on a specific set of core conditions. The first is warmth. This is the active communication of care and complete, non-judgmental acceptance of the person sitting across the room. Next is respect. A counselor must honor the client's autonomy, recognizing their fundamental dignity and their absolute right to make their own choices. Then there is genuineness, sometimes called congruence. It requires the counselor to be an authentic human being, fully present rather than hiding behind an aloof clinical mask. Concreteness ensures the dialogue stays specific and actionable. It pulls the conversation out of vague therapeutic platitudes and focuses the client on clear, tangible realities. These conditions are often mistakenly dismissed as soft skills. In reality, they are the structural, load-bearing pillars that determine whether a client will tolerate any clinical interventions. Of all these core conditions, empathy is perhaps the most critical and the most frequently misunderstood. True clinical empathy is the ability to accurately understand and reflect back a client's internal experience, as if you are perceiving it entirely from the inside. To use it effectively, a counselor must draw a strict boundary distinction between empathy and everyday sympathy. Sympathy involves feeling sorry for someone from the outside. While well-intentioned, it subtly establishes a hierarchy that places the professional above the suffering client. Empathy actively joins the client exactly where they are. It neutralizes that hierarchy and builds the alliance by proving to the client that they are truly heard. You can hear the difference in the language. Reacting with, "That must be so hard, you poor thing," is sympathy. Reflecting, "It sounds like you feel trapped and don't know how to stop," is empathy. Mastering this distinction prevents the counselor from devolving into a pitying authority figure, ensuring the client retains their agency and remains the active driver of their own recovery. When two people engage in this kind of deep relational work, powerful psychological forces inevitably surface in the room. The most common is transference, which occurs when a client projects the feelings and expectations from their past relationships directly onto the counselor. Without realizing it, a client might begin subconsciously reacting to the therapist like a punishing parent, a judgmental authority figure, or a romantic partner. The inverse is countertransference. This is the counselor's own emotional reaction to the client, driven by the counselor's hidden personal history. A counselor might find themselves feeling unusually irritated, overly protective, or driven by a sudden need to rescue a particular client. Both forces are entirely normal. They are inevitable data streams, providing insight into the therapeutic relationship, not signs of clinical failure. Because they operate below the surface, consistent clinical supervision is required to notice, reflect on, and safely manage these dual dynamics. Leaving countertransference unexamined is dangerous. It is consistently the leading cause of impaired clinical judgment and severe boundary violations in the profession. Ultimately, skilled practice requires reading the client's current state and selecting the exact intervention they need at that moment. A highly concrete, action-oriented client may thrive with cognitive behavioral therapy. Meanwhile, a client trapped by rigid, self-defeating beliefs requires the active disputation found in rational emotive behavior therapy, developed by Albert Ellis. If a client habitually numbs or avoids their emotions, they benefit heavily from the strict present-moment focus of Gestalt therapy, associated with Fritz Perls. A client mired in excuses will respond to reality therapy's demand for accountability, while a client who is still deeply ambivalent needs motivational interviewing before anything else can happen. The art of addiction counseling is integration. It means holding the core relational conditions constant, while simultaneously flexing your specific clinical techniques to match the person sitting in front of you. That integration requires one final, necessary lens: cultural humility. The theories we rely on were developed in specific cultural contexts. Because norms around emotional expression, directness, and the meaning of family vary drastically across cultures, those theories must be continuously adapted. Effective practice focuses on fitting the clinical approach to the client's unique needs, rather than forcing the client to fit a pre-existing approach.